Hello.
So I'll request those who are not talking, kindly put your mic on mute. Okay. So good afternoon, good morning, good evening, whichever part of the world you are in. I'm Dr. Nina Raina. I'm the Senior Advisor for Maternal, Newborn, Child, Adolescent Health, Aging and Midwifery. A very warm welcome to the panelists they who are with us. I see Professor Michael Valenzuela, Dr. who is from our headquarters, Geneva. Dr. Yuka, who is working with us, a colleague in headquarters. Dr. Anjan Trikha, who is working as a professor in Department of Anesthesiology, All India Institute of Medical Education, Delhi. And Dr. Kitty, who will be, I think, who has also joined us. So we have a very esteemed panel who are going to be talking about, our 10th webinar, which is managing access to health services of older people in COVID-19 pandemic. As you all know, this is our webinar series promoting health throughout the life course during COVID-19 pandemic. And we had planned 11 webinars in collaboration with Indian Institute of Public Health, Gandhinagar. Professor Dilip Mavlankar, who is the director of the Indian Institute of Public Health, Gandhinagar, and myself, we had good collaboration for this 11 webinars. Today is the 10th webinar, and we have one more, but at the same time, we have 4 simultaneously planned webinars on school reopening along with UNICEF and UNESCO. We have another a series of webinars which we are doing with our WHO Collaborating Center on COVID in children. So there are a series of webinars, and I see that over a period of time, I think we are developing webinar fatigue. But I see that this is the only platform which is attended by so many participants to really learn, to get the updates, to learn positive and successful experiences from the countries. So today we will be, this webinar will be coordinated by Professor Abide, who works as a consultant with us. He is retired as a professor and head of the Department of Geriatrics from AIIMS. So he's working with us as a consultant on healthy aging. So there are key points which we'll be discussing. As you know, that during this COVID-19, there have been direct impact in the form of death. There have been indirect impact in the form of disruption in services. And these disruption in services are not only for COVID, but then also for non-COVID related issues. These essential services for maternal, newborn, child, adolescent health were affected, but then this disruption was also huge for older people. As we know that older people are bearing the brunt of infection, deaths, as well as disruption in services, especially the non-communicable diseases, because at this age, you see a lot of them suffering from diabetes, hypertension, and many other problems. So today, I think we are going to be talking about management of COVID in the older population. What is our WHO guidance on it during COVID-19? Dr. Yuka, my colleague from headquarters, will be talking about that. Challenges in the management of older COVID patients in intensive care will be covered by Dr. Anjan Trikha. And I think that's where, intensive care is extremely important, not only to save lives of older people, but also to reduce the sequelae, which really is, we are learning as this pandemic is evolving. We are learning a lot about the after effects of this COVID-19. Thirdly, we want to have an experience from Thailand which will be presented by Dr. Kitty, who is the Director, Bureau of Elderly Health, Department of Health, Ministry of Health from Thailand. He'll be talking about innovations in ensuring healthcare services for older populations during COVID pandemic. And lastly, we'll have from one of our colleagues an insight into preventing a decline in intrinsic capacity amongst older people, the integrated care of people, older people, which is a pilot program implementation. Professor Michael will be covering that. We call it ICO. So with these, I'd like to invite Dr. Pingley, who is with us from IIPH, Gandhinagar, to say a few words. And then I'll hand it over to Professor A.B. Day to take us through the presenters and presentations. I would also like to mention that all these recordings are there, will be put on the YouTube. The previous ones have already been uploaded. And these presentations will be shared with everyone. So those of you who would like, and I think the panelists here who have shared their presentations, I presume that they have no objection to sharing of their presentations. And in case there is any, kindly let us know, and we can change, or we can, share whatever you want to share with all the participants. Over to you, Dr. Pingley, for your comments, please.
Yeah, thank you so much, and very good afternoon to all. I'm sorry that there are some technical glitches and my video is not visible, but I hope you can hear me. So first of all, I'd like to thank WHO for this opportunity to IIPG to collaborate with this excellent series of webinars, and it has been a wonderful experience, and I'm sure it has been very useful. I welcome all the participants to these webinars on behalf of IIPG. IIPG, or Indian Institute of Public Health Gandhinagar, was established as a public-private partnership between Public Health Foundation of India and Government of Gujarat. So in 2015, it became a university, state university under the Act of Gujarat Assembly. We started with a postgraduate diploma course in public health management, and now we are running MPH and MHA, which are full-fledged 2-year courses, which are our flagship courses, along with many other training and teaching programs, diploma programs, and distance learning programs. So with this, I welcome you all once again and hand it over back. Thank you.
Good afternoon, everybody. We have this very important webinar on clinical issues, or rather health issues. We have talked about health promotion, long-term care, and now it comes to the brass tacks as to how older people can access healthcare, and when they're in the health system, how best they can be treated by the health system. So on the 4 lectures, I invite Dr. Yuka Sumi, our good friend from WHO headquarters. Dr. Yuka, please.
Thank you, Dr. Day, and thank you, Nina, Dr. Nina, and congratulations to the Seattle colleagues as well as the Indian Institute of Public Health of this series of webinars. And I see that more than 200 participants, joining in this platform, and that is really wonderful to be here with you. Okay, next, please. So today I will talk about care for older adults during the COVID-19. As you know, older people are at high risk of experiencing adverse outcomes from COVID-19 than other population groups. You see that in the blue bars, actually the patient number, but actually if you see the red, orange point, that is a case fatality rate. And data from this is 71 countries suggests that case fatality rates increase exponentially with age. Next, please. So this is the result of pulse survey WHO conducted on continuity of essential services during the COVID-19 pandemic, aimed to gain initial insight from country key informants into the impact of COVID-19 pandemic on essential health services across the life course. The survey result in this report can improve our understanding of the extent of disruptions across all services and the reason for disruptions and the mitigation strategies. In general, disruption of essential services were reported by nearly all countries, and more in lower income countries than higher income countries. The great majority of service disruption were partial, which was defined as a change of 5 to 50% in service provision or use, and the service complete disruption was defined as a change of more than 50% in service provision or use. I highlighted the services that will be actually relevant to older people. One is rehabilitation, and the other is NCD diagnosis. The other is treatment of mental health, and the diagnosis and the cancer treatment, and the palliative services. As you can imagine, there are so much disruption in essential services. Next, please. Even though COVID affected all age groups, as I showed, older age and underlying non-communicable diseases such as diabetes, hypertension, cardiac disease have been reported as risk factors for severe disease and death. Older people are often affected by these conditions, so they are one of the most vulnerable populations. And second, older people may present with atypical symptoms such as fatigue, diarrhea, loss of appetite, delirium. Actually, delirium is one of the most common symptoms for older people with COVID, and even without fever. In the beginning, before we know the clinical symptoms of COVID, we say that dry cough, fever, this kind of respiratory symptoms are common. But once we get to know what is the COVID symptoms for older people, these atypical symptoms are well known for older people. And sometimes their caregivers may notice the change of condition and behavior, such as they are not as alert or mobile as usual. Asymptomatic cases, so without symptom, are reported among residents at the time of testing, 7 to 75% in long-term care facilities. So it is very difficult to diagnose the COVID-19 among older people. Number 3, older people may need for medical and assistive care for their conditions and impairment include home-based visit and community care, and that are most likely disrupted. As you have seen that nearly 60% of non-communicable disease service users are older adults aged over 60, and the survey say that over 40% of countries reported these health services for hypertension, diabetes, and other NCD management were partially or completely disrupted. Next, please. And then on top of that, measures for COVID-19, stay-at-home orders or lockdown, actually result in social isolation and loneliness, particularly for those who live alone. Disruption of care and support, declines in physical and mental capacity. Depressive symptoms are common among older people, and some older people are coping with grief and loss of their family members and friends. And then number 5, older people can go back. Yes, older people may not have an equal access as younger people to accurate, updated information due to their impairment, for example, hearing loss, visual impairment, and cognitive decline. Because information evolves every day, and then maybe younger people have more access to the internet, getting accurate information in timely manner, but maybe older people do not have the same access to these informations. And the internet can be expensive, and there might be a lack of skills for digital technology. And number 6, less than 20% of older people of retirement age receiving the pension, according to UN policy brief. And social security net does not always cover older people. So economic uncertainty may affect more on older people, that results in less access to food, hygiene products, as well as healthcare. Next, please. So what WHO has been doing to respond to the older people's needs? So we have a great network of experts to provide expertise on care for older people. First one is a clinical guidance for older people with COVID-19. That was first published around actually March, but it has been updated, the situation evolves. This is a clinical management of COVID-19, and there is a section for caring for older people with COVID-19. The content includes person-centered assessment and care, respect for values and preferences for the course of their health and management, involvement older people in decision-making. And there is a training course in WHO Academy, which is a digital app. Next, please. And in detail, actually, we provide how to recognize the risk of COVID-19 and how important early recognition is, because older people is at risk for the early deterioration. And also we emphasize the importance of person-centered assessment and personalized care plan, including rehabilitation, advanced care planning, and palliative care. Also, as you may know, older people may have multiple medication before COVID. So medication management, including reducing polypharmacy, is very important. And then also we highlight that the management of morbidity and declining in physical and mental capacity, we call it intrinsic capacity, is also important. Second, this is about maintaining essential health services for older people. So first one was targeting clinicians, including medical doctors, pharmacists, and nurses, all the clinicians who take care of older people. The second one is more for targeting decision makers and managers at the national and subnational levels to reorganize and maintain access to safe and high quality essential services. There are two parts. One is the operational strategy for maintaining essential health services, and part 2 is life course and disease consideration. And in part 2, we have older people section, NCD section, and mental health. As you can see, all the slide has the link on the bottom, so you can have a look in detail after the webinar. So in this, next please. Next please. Yes, that's what I was talking about, sorry. The next please. So in this maintaining essential health service for older people, including how to promote physical and mental health during COVID-19. So regardless of having COVID-19, actually it's really important for older people to promote physical and mental health. That include information sharing on preventive measures and monitor for negative impacts of social isolation, and how to report elder abuse. Actually, during the COVID-19, there are increasing number of elder abuse. And also we need to prioritize psychosocial support. And then we need to understand how to maintain care for older people with impairment and disabilities, with underlying conditions, and who are care dependent. Especially for those who are care dependent, we need to understand how to support caregivers, because maybe the caregiver support for home visit or daycare center as a respite care has been disrupted. So all the care burden on families actually increasing during the COVID. So it's really important to make sure caregiver support are maintained. Next, please. So the other work is about community-based healthcare. I touched on a bit about, daycare center or home visit, because it's really important to have older people, the place they live. So we say that aging in place. So we are not promoting, to have a facility-based care. It's more community-based healthcare. But how to maintain? It's really important how to maintain from the service side, also the demand side. Actually, one of the reasons disruption or users stop using community-based healthcare is the fear, because even though they are willing to provide a home visit, and older people or their family are afraid to have some visit from outside. So it's really important to have proper IPC measures, as well as good communication of these people. Next, please. I think the long-term care facility guidance are covered in the last webinar. So I will briefly talk about here. So we have two main guidance. One is IPC measures in long-term care facilities, targeting long-term care facility managers and focal point. Next, please. This next one is a policy brief on mitigating the impact of COVID-19 across long-term care services. As you may know, the 40% of COVID-related deaths come from long-term care facilities, and in some high-income countries, maximum 80% of deaths coming from long-term care facilities. And the main users are older people. So it's really important to understand what is the needs of people from long-term care facilities. Next, please. We have been talking about the lack of data for care of older people. Without data, it's really hard to understand what is the needs and what kind of strategies actually making a difference. So monitoring and evaluation is one of the key factors. So in this guidance, actually we promote to have age disaggregated data and also sex disaggregated data, as well as what kind of infection prevention control is taking place in long-term care facilities. Next, please. So we have several guidance, technical guidance, based on the expert opinion. We provided and we published this guidance. So what is the planning for the next step? So actually, clinical management of COVID-19 will be updated very soon, based on the increasing number of evidence. And there is a scientific brief is coming. What is the impact of COVID-19 on long-term care facilities? As I said, data and evidence actually should inform the policy making. And also we will have a healthcare, long-term care facilities readiness and IPC checklist. And now many people are talking about COVID-19 vaccines. Then how to assure the equity and the efficacy and the safety of COVID-19? So we are actually developing the guidance on national development of and vaccination plan for COVID-19 vaccination. Next, please. So I just want to remind all participants, there is no typical older person. It is really good that the COVID situation actually brought us more attention to older people. Even though this statistics is really bad for older people, we need to take this opportunity to strengthen the care for older people, but don't put older person in one box. Older people are fragile, older people needs to be protected. Because in fact, there are so many older people contributing to society, and there are so many caregivers who are older people. This is the last slide. In this August, the member states of 73rd World Health Assembly called for 10 years of concerted action. to foster healthy aging by endorsing the decade of healthy aging up to 2030. So this is an opportunity to bring together governments, civil society, international agencies, professionals, academia, media, and private sector for collaborative action to improve the lives of older people, their families, and the communities. And as you can see, there are 4 action areas highlighted in the decade of healthy aging. That includes number 3, delivering person-centered integrated care and primary health services responsible to older people and providing older people who need it with access to long-term care. All action areas are relevant to COVID and post-COVID, but providing care is very important and to think about what is the needs of older people. Thank you very much for your attention.
Thank you, Dr. Yuka. We now have this topic or the presentation by Professor Anjantrika, the Professor of Anesthesiology, All India Institute of Medical Sciences, looking after the intensive care unit for COVID patients in the hospital. For the audience, please write down your questions and send it to the organizer. And after the presentations are over, will be taken up one by one. So please send the questions. Dr. Professor Trikha, please.
Thank you very much for inviting me to be talking on this forum. This is the second time I am talking on such a forum at the WHO. One was about a month ago, but this time I talk about a totally different topic. The earlier speaker has rightly said that there is no typical old patient, and I will talk about old patients. Next slide, please. Okay, just to let you know, people who are not from India, I work in this hospital, which is in Delhi. It has been the best possible public hospital and a medical school for the last 2 decades, year after year. And the first of the photographs where you see the name is on the western side, and the other side where you see a garden, it's on the eastern side. However, about 1.5 kilometers away, there was a trauma center, which for the COVID pandemic was shifted to the main building, and we have now a trauma center, which is a dedicated COVID center with about 250 odd beds, out of which 80 are ICU beds and about 40 to 50 HDU beds in wards. And you can see one of the photographs on my right, the bottom one, where we had converted a huge area to an ICU, and you can see me standing there and our health minister also there, we were waiting during the lockdown, hoping that the patients will not come because there were a lot of issues regarding this. But ultimately everything is gone full, and we all know that we are now bursting as far as patients are concerned. Next slide, please. Okay, this is just a snapshot. Well, it's today, it's 20th of October, yesterday's snapshots. At this very center, I've had about 3,084 patients, out of which 821 patients have been in the ICUs. So you can imagine the kind of workload we have. We normally do not admit mild patients at all to our center. It's only moderate and severe patients. Next slide, please. Okay, this is again unpublished data from my hospital on about 30th of September, and this shows you the breakdown of patients who were there with us from the 3rd of April when we had our first patient coming in. So as you can see, we have a large number of patients, about 193, who are above the age of 60 years. And this is where this talk is going to talk about how to deal with these patients and what do we do when we try to treat patients who are old. I personally think 60 years is not old enough. But then for the sake of grouping, I have grouped them to 60 and above, because in India, still for government jobs, 60 years would be a retirement age from active service. Next slide, please. Okay, this is an overview of my talk for the next 10 minutes. I talk about tri-aging during a pandemic as far as old people are concerned, and talk also about end-of-life care, advanced directives, especially during the COVID season. And then what are the challenges which I have been facing as far as the older people are concerned regarding their organ dysfunctions, There are hardly any drugs which have been proved to be effective, but whatever they are, we've had issues in the older age group, and then obviously treatment challenges in these group of patients. A slide or two of delirium, which is so common in the older age group patients, and especially when you have COVID patients in the ICU, and then loss of family and contacts. Next slide, please. We take each one of them at a time. The first thing is triaging. When the pandemic started, we had all heard stories from various parts of the world where the moment you had an older patient, he was left and not taken to an ICU, maybe left in the ward, or maybe not even admitted in a ward. But now over the past 6-7 months, at least at my center, we've realized that triaging by the age, which is a number, is not really correct. You could have a good 70-year-old man, a good 75-year-old man who's good to the society, good to himself. He's doing well for himself. So triaging in a pandemic just by age is not really on, and we don't follow it. There have been issues of triaging by the need of or the outcome of the medical benefit which we give in an ICU to an old patient, or you could practice the first come first served basis. Well, it's a bit of a issue here as far as an ICU is concerned, because if you try to treat patients on first come first served basis, then maybe you are stuck up with a lot of old patients who have poor outcomes, and then you can't do much for the younger patients. So every place, every ICU, every critical care units should have their own criteria how to treat with triaging in a pandemic, and this criteria should be accurate, explicit, fair, and should be told to the people, or the government should be aware of it in advance. There should be no issues as far as or discrimination as far as race, religion, ethnicity, sex, or economic status is concerned. It is easier said than done. I also know it, and it has been tough for us when we thought of triaging, especially when we had a lot of old patients coming to us with various comorbidities. I talk about them in a couple of slides. But ideally, if one has to triage, as per a standard policy, and as far as possible, one should not try to change that policy. You really can't have one set of rules for one patient, or let's say in 1 month, and then you change the rules in the next month. At the same time, one must realize, and I also face a lot of social pressures. You have people from, let's say, politicians who are very old, and they would put a lot of social pressures. If you had a triaging policy, maybe a 90-year-old politician should be coming in. But then we all survive these social pressures, and we know how to deal with them. And if we have a sticky patient or we have a problem, we know how to go around it. In an Indian ICU, this becomes difficult, as I mentioned, especially when you are dealing with politicians, more important. And as things we've had, if you remember what I showed you earlier, we've had about 6 patients who were above the age of 90, and luckily 4 of them went back home. One went back home last week, and it was a tough call for us, because they were all politicians, and or their parents, or their politicians who were retired, or politicians, as a matter of fact, a politician never retires. So these were the ones where we would have avoided them getting into the ICU. We would have tried to somehow do whatever we could at their own houses or in COVID care centers, but we had to accept them and take care of them in ICUs. Next slide, please. Now we come to the next one. After triaging, end-of-life care. We all know in an ICU setting, end-of-life care is very important, and there have been certain guidelines. So many societies have their own guidelines. But when we come to COVID, it came as a bang. These end-of-life care things were always there, as far as advanced support was concerned, invasive monitoring was concerned. But once the COVID came in, people were really not aware what is to be done, and it has come with a bang. And we've had a lot of issues taking care of old patients with COVID and malignancy, leukemias, various kind of leukemias. At the present time today, I would have about 5 patients who are above the age of 70 with carcinoma lung admitted with me, and 2 of them are with carcinoma gallbladder, and 1 with carcinoma of pancreas. And mind you, they are not moribund. They are comparatively healthy people. If they wouldn't have had COVID, they would have been they would have been managed at their own houses, and they would have maybe lived for how many years, I really don't know, nobody knows. But this is a big challenge for us. Whether we admit a patient who has carcinoma lung, we know that the life expectancy is short, but he is in reasonable good health, and we are very sure that he's going to have a good, fruitful life for another 5 or 6 or 7 months. Do we admit him into the ICU, take care of his oxygenation, maybe give him a non-invasive ventilation or whatever, and even tube him and put on a ventilator, or avoid getting him? These are the kind of challenges which I have to face day in and day out, and I have my own way to get around that. If a patient is good enough, we never say no to a patient who has malignancy. We would never try to have a patient, an old patient with malignancy and COVID, if he was up and about before he got COVID and he has at least 3 months to live. It's very unlikely that I would ever say no to this patient. Then we come to the other thing, advanced directives and living wills, which are again very important for intensive care units. Ever since the COVID has come, these things have gained importance once again, because especially in public hospitals where you don't really charge much in India, all treatment of COVID disease per se in a public hospital is free of cost. It could mean that a ventilator and ICU care or whatever medications the patient requires, they're all free. So finances is not an issue in public hospitals in India, but still in countries where advanced directives and living wills are a norm, are very much done, one is easier off, and one can take care of patients keeping into mind their living wills or whatever they have directed. But in India, it's a different ball game. Majority of the times there are no directives, and majority of the time, instead of advanced directives or a living will, there would be family directives. The family normally comes in and tells you what do they really want to do or how far you should go, and then that too, one has to be, that too, if you have to follow, is a bit of a challenge, because one has to be very clear who in the family you are talking to. And it's not uncommon with us that old patients with COVID who are with us, a family member says, yes, fine, we really don't want to go to the whole extent, and we could downgrade from the ICU to somewhere else where he could be more comfortable. As a rule, we are not discharging patients who come into the critical category or severe category home unless they are negative. So the family can decide, and at times the families have told us that we could downgrade these patients to wards. But sadly enough, even in the wards, they lie alone, because we as a protocol, as a rule, we don't allow family members or the relatives or friends to be visiting these patients inside for the fear of spread of infection. Once we have decided, and once I have talked to the family, we honor their decisions. We try to document them because they have not been earlier documented. The general thing which I've seen is that the family directives are not to do anything invasive. And as far as an ICU is concerned, in a COVID old patient, invasive would mean a neckline and heart line. Obviously, a Foley is on, or you could put a diaper, and no intubation and no ventilation. So even today we have, I think, 2 patients in our ICU who have these family directives. They're about 70-year-old lady, both are women 70-year-old, who are on NIV, and we are very clear that as long as they are on NIV, they are a bit conscious and they can eat a few things or drink a few things. That would be the end of it, and we will not be intubating them or then finally putting them on ventilator or for tracheostomy. The challenge in this is something else. The challenge is a family directive, which is not a legal issue in India as far as at the present time is concerned. They keep on changing. They keep on changing with the number of family members who come on day 1 or day 2, or somebody comes from another state. So one has to accept that challenge and keep on waiting for some time before you can really take care of these things. Next slide, please. Okay, this is a snapshot again from an article which was published in JAMA. This was a short communication, and this shows what has been happening, the kind of advanced directives documentation has increased from January 19 to April 2022. If you see the both the bars. Next slide. But this is not in India. In India, these things don't happen. Next slide, please. This never happens in India. We are not really doing all this. We come to the next challenge, which is pre-existing diseases and COVID-based organ dysfunction. This is where our challenge lies in old people. They would have, we all know that they are more prone to get COVID infection, but we also know that they would have diabetes, they would have hypertension, various cardiac disease, coronary artery disease, stents, cardiomyopathies, chronic kidney disease with or without dialysis. And this is one group which is a problem for us most of the time, because these patients who are on dialysis, maintenance dialysis, would need it every alternate day or maybe twice a week. They really can't go anywhere, and they are with us for a long time. And these patients try to feel who are with us are otherwise healthy, and they really can't go and get dialysis done on non-COVID centers. Other pre-existing diseases which gave us a problem in these age groups are neurological disorders, old history of strokes, TIAs, or cerebrovascular accidents. When they come to us after they've had this and they have picked up COVID, then they are a big problem for us. We all at the same time must know that along with this, COVID is a generalized disease. Now it's no longer limited to the lungs. It's a generalized inflammation of the various organ systems. So we see the heart dysfunction, which adds on to the cardiac disease which the patient, if he had, it could affect the kidneys, and which will add on again to the CKD, or they could have a CKD grade 3 or 4 and then an AKI and then land up to dialysis. And a large number of these patients will have deep vein thrombosis, venothromboembolism phenomena, or pulmonary embolic phenomena. We have also been seeing quite a bit of seizures and strokes in these group of patients, especially the older ones. And we must not forget that older patients who are sick, or even younger ones, would have a lot of other manifestations of COVID organ system diseases in the ICU, which we'll have to deal with. We've had about 10 cases of old people who developed corneal abrasions because of the care in an ICU, and they have had skin infections because of basic COVID disease. And lastly, the challenge is to manage their psychological problems, especially in this era of COVID. They are old, they develop COVID infections, and they as such have some borderline depression, and they go into a bigger depression, and then we manage all that in an ICU. Next slide, please. Medications and oxygen therapy is a big challenge in these group of patients. Old age group, comorbid conditions. In an ICU, we have decided to go to the, take care of all these patients if you decide with everything possible. We all know that they would have drugs, treatment has been changing in the last 8 months. What I did in the month of April, most of the things I'm not doing today, because there is evidence to the contrary with so many things. We started with hydroxychloroquine. We were giving it them as a routine, but older age group patients, we were not giving it at all. And if at all, we thought because we had nothing else to give, we would order an ECG, and if they were heart blocks or arrhythmias, we were avoiding it. Same is true with remdesivir. This is one drug which is in fashion, though the latest results show that this also may not be useful as per the articles published last week. But then the problem in this was that we were not able to give it to older patients who had compromised kidney conditions, because the expecient with remdesivir would affect the renal function, and it was a contraindicated in patient who had a GFR of 30 or less. However, we had to make a case-to-case decisions. If the patient was totally knocked out as far as CKD was concerned and was on maintenance dialysis, then we didn't have a problem. But if he had an AKI and the patient was old enough, and we thought the patient's kidneys would recover, we'll do that. The same is true with plasma. The same is true with steroids, and same with TCZ. They are an issue when we give to the old patients, especially the old COVID patient. Next slide, please. Next slide. Next slide. Okay, this becomes very important because oxygen therapy is the mainstay of COVID patients, and in the older age group patients, we have realized that non-invasive ventilation, the masks don't fit, interfaces are a problem with these group of patients. So high flow nasal cannulas are much more accepted and tolerated because with these tight fitting masks, the patients feel claustrophobic and they don't accept it. Other issue which is very important in these COVID patients and is a problem in older patients, we know that awake proning works, we know that conscious proning works, but in older age group patients, because of arthritis, because of pains, because of poor muscle mass, asking them to lie prone for 14 to 16 hours is next to impossible. So very important modality of management of COVID patients is very difficult to be done in older patients. Even if they have been intubated and on a ventilator, it's very tough to prone them because they have fragile bones. You could really injure them, and they are very prone to get pressure sores. So proning in older age group COVID patients is a big challenge for all of us. Next slide, please. Next to is delirium. We all know that delirium has a prognostic value as far as older patients are concerned, and COVID older patients develop it quite a lot. And mind you, they develop it quite a lot. They develop ICU delirium. As a matter of fact, about 70% of patients in our ICU are older age group patients will develop them, and it has a bad prognostic indicator. So we tend to treat it aggressively. We tend to have, next slide please. We tend to see to it that we start their medications early. We try to rule out any hypoxia in these patients, but all these older age group patients would have video calls with their friends and relatives so that they can talk to them, and this we've seen decreases delirium. And early discharge of these patients, older patients, to their home is also a very good maneuver to decrease delirium. Next slide, please. To conclude, and this is my last slide, in COVID pandemic, older patients are more likely to land up in ICUs. It is difficult to triage them. If possible, do that, but respect family directives, and comorbidities and drug interactions play a very important role and is a challenge in planning this treatment. Thank you very much. Next slide.
Thank you, Professor Trika, being in the front line health worker in the ICU and then trying to save lives. Great to hear from you. Now you have Dr. Kitty from Thailand. Thailand did very good in, I mean, performance of Thailand in the during the pandemic has been great. Less than 60 deaths and less than 4,000 total cases in a population of 69 to 70 million. So we'll know how things have happened in Thailand and how successfully Thailand has handled the pandemic. Dr. Kitty, please.
Thank you very much, Dr. Day, and I also thank you, WHO and IPH, for inviting me to sharing the information and Thailand's experience about the situation and management of the COVID-19 pandemic. First slide, please. My outline of presentation will include the situation and then followed by the innovations for other people and in details later. Okay, now next slide, please. The situation of Thailand, as you know that many countries all around the world have been affected by the COVID-19 pandemic, and Thailand also have that problem, and we try to control the spreading of the disease. This is the situation, general information of Thailand. Population 66 million, and older adults that age 60 years and over is about 11.5 million people. That's around 17% of the total population. That is the proportion, the percentage of the elderly people in Thailand is about 17%. It's nearly reached 20%. Next slide, please. Now, let's see the situation of the COVID-19 in Thailand, and including the death number of the people in the elderly group. You can see by this slide that number of deaths of the COVID-19 patients in Thailand, the current number is, the cumulative number is 59 deaths. Among 59 deaths, this is a elderly group that age 60 and over, about 26 people, that approximately 45%. So you can see that the older population group is the high risk group. You can see that elderly people, there are many factors that make the elderly people high risk for severe illness, and they can get infection easily. And many older population also have the underlying medical conditions such as diabetes mellitus, hypertension, respiratory disease, and also mental conditions such as depression, stress, anxiety, etc. Next slide, please. So we have to be careful and have the strenuous strategy to cope with this problem. So in Thailand, there are many organizations try to produce the innovations that will help other people to face with the problem of the COVID-19 pandemic. As you all know that since the pandemic of COVID-19 occurred, that changed our life very much. We cannot do normal activities as usual, and this include some activities that involve health problem. When we have to go to the hospital, they also have the risk when we get into the hospital if in the crowded situation. That is also very high risk. And we usually recommend the older people try to stay away from the crowded group. And this is also the recommendation to people for age group, because we need social distancing other than the washing hand and face mask. We also use the strategy of social distancing. So this also have the effect of the getting the health service of everyone too, including older people. So many organizations in Thailand try to cooperate to launch some innovations that will help older people to get through this problem. Let's see the first one. This is for the prevention and protection. This is called Absolute. It is a chill and protecting spray. As you know that there has been the situation that we have the shortage of the surgical mask when the pandemic occurred. Many people try to use the fabric mask instead, and as we know now, it works very well. We can use fabric mask instead of the surgical mask in many conditions, in nearly all conditions, but maybe have some exception in that we need surgical mask. Anyway, when we use fabric mask, we can increase the protectiveness of the fabric mask by use the spray that we call Absolute. The content in this Absolute is a biopolymer that it will increase the protectiveness of fabric mask, just such as air microbial filtration and saliva microbial filtration, and also 83% more efficient for particle filtration, 0.3 micron. And importantly, is safe to use because the biopolymer is a natural substance found in a human body. So if we use this, we can increase the protectiveness of the fabric mass, and we can use this in the effectiveness nearly equal to the surgical mask. So this is one of the solution in the strategy of prevention and protection. Next slide, please. Let's see another innovation. This is in the strategy of health promotion, but it's not the pure health promotion strategy for this mini robot. It can also help us to give some simple care for other people too, especially the dependent older people. They can get benefit very much from this innovation. The mini robot is called Dinsor. Dinsor is the Thai word. It's a Thai word that the meaning is a pencil. A pencil we call it Dinsor in Thailand, and the producer just named it as Dinsor. The objective of this mini robot is to promote about healthcare innovation and technology of the elderly, especially in the situation of COVID-19 pandemic. It also works well. There are many functions in the Dinsor mini robot. As you can see in the upper left corner of the slide, that is the picture of the Dinsor mini robot. There are many functions, such as the patient or older people can call caregiver to provide service, and also it being used in the communication between care provider and family caregiver and family member. Dialing system is easy to use. They can touch the screen of the person, the picture of the person or the name that make us know that what person is on the menu, and they can easily touch that icon and they can communicate with that person that is can be caregiver or family member. Besides, there are another functions such as brain exercise. There something like simple game that have benefit for the brain exercise too, and it's also function as a reminder about medicine, taking medicine, something like that. And when the older people is out of sight of this mini robot, there will be also warning system to notify the caregiver or family member to know that maybe they go to some longer distance from the mini robot and made them aware to check that what is the condition at that time of the older people. And also this can have some entertainment to the older people too. And it also includes functions of providing care and special care for the patient that have NCD, such as diabetes mellitus or hypertension. There are many functions for this mini robot. Okay, next slide, please. Because there are various functions by promoting activities for elderly. We set it in the health promotion innovation because it also can stimulate the older people to have some exercise to promote their health too. And this is the tool for communicate and management for care too. But there still have some problem in the user function, but this can be solved, not very difficult. Next slide, please. Village health volunteers, that we call them unsung heroes, because they the group of people in the community that they have the service mind, and they go to the village and check that is whether the other people is stay well and healthy, and they try to check if there are anyone who have an early sign of the abnormality, so they can screen and refer to the service center nearby. And then they help very much, and also in the delivery of medicine, they also help to make the other people can get medicine as usual. Yes. Next slide, please. LongCare mobile app. This is the innovation of the Chulalongkorn University. This can help us very much to pre-screening of respiratory symptoms, because other people will not showing sign very much. So if we can detect early, this can help us very much. So this mobile app used for the test of lung care. So we can pre-screen about the respiratory symptoms, and it's easy to use. There will be signs that show that what is well or very or bad or moderate. Next slide, please. Next slide, Ninja mobile robot. This health monitoring and medication reminder. It also help in speech therapy and rehabilitation too. This is in the strategy of treatment and service. Next slide, please. This also from the Chulalongkorn University. Telemedicine and telepresence, health monitoring and navigation. So there are odometry to tell us the distance and try to avoid collision, that obstacle avoidance. And this is a help for navigation. Next slide, please. Next slide, please. Okay, excellent happy homework. This for the municipality Khao Prangam of Lopburi province. They cooperation among the community, municipality, private and public sector, and community, and they take care health, social, environment activities, and also use technology to help. Next slide, please. View for Life. View for Life is from the Virayak University. This can they can move from the chair or bed to the wheel easily. This is the View for Life of Virayak University. Next slide, please. Next slide, please. Smart wheelchair. Next slide is about smart wheelchair. Next slide, please. Smart wheelchair. Okay, eye tracking. There is an equipment for detect eye movement when the people they look at any place. This wheelchair know and then can bring them there. Innovation. Another innovation is medicine dispenser. Next slide. Medicine dispenser. They will remind to not forget. Next slide. Next slide, please. Smart home medicine dispenser. This will remind about the medicine, so not to forget and taking medicine. And this is just linked to mobile phone application too. Okay, for the accurate medicine taking. Next slide, please. Innovation for other people. Next slide, please. Long distance healthcare innovation. They need not to go to the hospital for some condition. Where we have the application from the National Innovation Agency of Thailand. This can help they not go to hospital very often. Go to only when necessary. And the last one about the data system. This is very important. Long-term care. Next slide, please. That will be the last slide. Okay, long-term care program 3.3. This care manager, caregiver care plan. This is very useful for the dependent older people and also dependent people in other age group too, because we have get the information of care manager and caregiver and also care plan for anyone. So this is help very much, and we can gather the information from this and link to the mobile phone, and it's user friendly. This can help us to monitor and evaluate the condition of the older people, especially dependent people. This can beneficial very much, especially in the era of the COVID-19 pandemic. Okay, this is for the Department of Health, Ministry of Public Health, and they cooperate with the National Health Security Office and also Ministry of Public Health of Thailand that create this program to help the older people. Yes, that's all for my presentation today. Thank you very much.
Thank you, Dr. Kiti. Now we have the last presentation by Professor Michael Valenzuela from the headquarters working on the ICOPE implementation project. Professor Valenzuela, please.
Thank you to the WHO and CIRO for the opportunity to talk about the ICOPE program. Next slide, please. And I guess unlike the rest of the talks that we've had already, this talk is kind of more future orientated with the realization that, you know, we will get past this COVID pandemic together. And there will still be this enormous challenge of an aging population, and how do you promote healthy aging around the world? And first of all, in terms of definition, the WHO defines healthy aging as the process of developing and maintaining functional ability that enables well-being in older age. So that's really key, that functional ability is at the top of that pyramid when it comes to healthy aging. And if we break that down a bit, the WHO has a key concept of intrinsic capacity, which is the combination of physical and mental capabilities and capacities of an individual. And that a functional ability is the combination interaction of those intrinsic capacities with the environment. So a good example in this case is if someone may have poor vision intrinsically, so they might have an intrinsic capacity of poor vision, but if that is corrected with eyewear, with glasses, then that's the interaction with the environment, which then allows that functional ability to be returned and the person to be able to go on with their day-to-day activities. So next slide, please. Now, through a process of collaboration and convening an expert group, which is called the consortium, the Clinical Consortium for Healthy Aging, CCHA, which is a number of experts from around the world over a number of years, in fact, and through Delphi processes. These were the main domains, the 6 main domains that were used to define intrinsic capacity. So we have limited mobility or mobility, nutrition, vision, hearing, cognition, and mental health, specifically depressive symptoms. And if there is one truism about aging and the geriatrics approach to medicine and the healthy aging approach, is how intercorrelated all these domains are in older people. So we've heard already that there's no such thing as a typical older person, but if there's one truism about older people, is that the interdependencies between these domains increase with age. So in other words, should you have, for example, a period of depression and low mood, that is very likely to impact your mobility and your nutrition and your cognition in older age, perhaps even more than in a younger person, because these things are so interlinked. And so that's kind of one of the key first principles of the ICOPE approach, is the 6 core domains and how interrelated they are in order to support general function. Next slide, please. Now, the I guess the philosophy behind ICOPE and the objectives is that if you look at the red line as a hypothetical, that during the life course, one may transition from a period of high and stable intrinsic capacity, and that might then start to decline. And in the worst case scenario, that accelerate to the point that functional ability is impaired. Now, the ICOPE is essentially trying to counteract that red trajectory and push it up into that blue type of trajectory, so that, for example, rather than moving into the area of significant loss of capacity, just might have some minor decline, or if you were to have minor decline, maybe push it back into high and stable capacity. And so the way that ICOPE goes about doing that is by targeting at multiple levels changes to the way we go about things. So ICOPE conceptualizes changes in terms of healthcare services, long-term care, and environmental changes. Next slide, please. And this is captured by this kind of concept diagram where, in order to implement ICOPE effectively, there will need to be changes at the macro level, which is really about systems and the way health systems are designed and the way the communities interact and conceive of older people. There'll need to be changes at the service level as well, so in the way health structures, health systems are organized, and the way they particularly engage with community health versus kind of hospital-based health systems. And then in the middle is the micro level, which is really changing individual persons' functional ability outcomes and healthy aging outcomes. And that is really about maximizing intrinsic capacities and functional ability at the individual level. Next slide. And that's the level that I'm going to focus on really for the most of the rest of the talk. ICOPE has already developed tools for understanding the attitude and the posture of systems and service levels, and that's called the ICOPE implementation scorecard. But for brevity and perhaps for the interest level of the audience, I'm going to really focus at the micro level. Next slide, thanks. And so the key resource here at the micro level is what's called the handbook, which is the guidance on person-centered assessment and care in the primary care setting. This, in the first instance, is a physical paper resource. So it's quite a thick book. And next slide. And it goes into some detail in those 6 different intrinsic capacity domains. It presents both a generic pathway and a specific pathway for each of those domains. So speaking generally, these pathways begin with some kind of screening question to try and triage whether the person in front of the health practitioner is at risk for a decline or impairment in their intrinsic capacity. If they are, well, then there is suggestions and recommendations on how to assess this in some more detail. And then critically is how to best manage these issues, both at the health level and very importantly at the social environmental level, because the second truism here is that amongst older people, it's that interaction between their intrinsic capacities and their social environmental environment, which is so key. And really, that combination, that interaction is what's going to determine whether the person will go down, let's call it a negative longitudinal trajectory or an optimized longitudinal trajectory. So then step 3 involves developing a personalized care plan for that individual, which responds to all of these issues. Step 4 is then handing taking responsibility for the person in terms of the whole health setting. Is that person going to be managed at that particular centre where the assessments have been done, or is it going to be referred on to other services? And then step 5 is ensuring that there is a community around the person to support them achieve these goals. And so, as you can imagine, if there is an ICOPE pathway for mobility, nutrition, vision, hearing, cognition, mental health, it's going to become very complicated, and in fact it becomes in practice impossible to do this simply with paper and pen type of resource. So next slide. Specifically because of all the interactions and cross-references between these pathways. So that is why I guess the clinical wisdom embodied in that handbook has been translated and transferred into the ICOPE handbook app, which embodies all of those guidelines and flow decision-making flow diagrams, and helps a healthcare practitioner implement the ICOPE approach. And I should point out that this ICOPE approach, the primary target of the handbook are field workers, primary care practitioners out there in the community. So we're really trying to target, particularly those member states that may not have as advanced and as developed primary care structures, and where people at the coalface really need this kind of integrated care that no one else can provide. So at the moment, the ICOPE handbook app is in a demo version, meaning that we're evaluating its performance in select field sites. That demo version is now available in a number of languages, as you can see down the bottom there, and is being currently evaluated in the field in Andorra and in China. And that's where we can move to the next slide. And the vision is for that ICOPE digital app to then be available once it's gone through our ICOPE implementation pilot program. So in terms of some context, you will all be aware that the UN Sustainable Development Goal 3 is about the health and well-being of the population around the world, and obviously older people's health and social care needs are critical to that. Yuka at the beginning alerted to us all and reminded us that the World Health Assembly has ratified the 2020s as the decade of healthy aging, and 2020 is proving to be a really remarkably challenging start to that decade of healthy aging. Nevertheless, it has highlighted how key the healthy aging challenges and opportunities there are all around the world, and how diverse that is. In that is the stated aim of delivering person-centered integrated care and primary health services. And ICOPE is the lead, I guess, tool for achieving that around the world by the WHO. And the ICOPE has been incorporated into the WHO's global goods plans. Thank you. For the next slide. And so I became involved in this program early in the year, and we began through our core team, which involves Yuka as well as Erica Uma, beginning really with the end in mind. So if you can ignore the kind of right side of that diagram with the small dot points, but if you just look at the main objectives, and we start at the top, the main objectives of ICOPE is to raise and protect the intrinsic capacity of older people around the world, and therefore optimize their functional ability. So that's our end goal, which means that ICOPE needs to be adopted around the world, and which means that member states need to be convinced about the cost effectiveness of displacing current standards of care with this approach. So that's where our 3-phase implementation program comes in. Again, moving backwards, that means that we'll transition through a multinational evaluation prospect, preceded by a prospective field testing, preceded by where we are now in the implementation readiness phase. Thank you. The next slide. So the ICOPE implementation pilot program is 3 sequential programs of work, conceptualized as ready, set, go. So as I mentioned, we are in the ready phase at the moment. And the objectives of the ready phase are to understand and address the questions of what is the usability of ICOPE out there in the real world, in the field. And so we're currently engaged with a number of field sites and member states around the world to begin to address that. And number 2, moving from the micro to the meso and macro phase, what is the maturity and readiness of the health services and systems to implement ICOPE? In terms of set or phase 2, the key questions there are, if we're going to implement ICOPE in the field, what would be the key process and outcome indicators of success? And on a practical level, how will we actually collect that data, manage that data, and enable our health practitioners to use it meaningfully, and then aggregate that data to be able to determine the insights and really understand how are we going to run a multinational trial, which is the objective of phase 3. So in this slide, we're talking about now the methods involved, or the mechanics of these 3 phases. So in the ready phase, which we're in now, we're looking at and assessing the real world usability of the ICOPE handbook and the ICOPE app through a readiness survey and through using the ICOPE implementation scorecard. In the next phase, we would be organising prospective study. So if you could just go back one. Just go back one. Back one more, please. Thank you. So we're up to the set phase, is a prospective study in 2 member states where we would essentially implement ICOPE, provide support to those sites, have the IT set up to aggregate and govern that data, and really show us in a test case scenario, a stress test scenario, what's working, what's not working, what are the right outcome measures to be using in our phase 3 or the GO study, which should be a multinational randomized study to essentially validate its effectiveness. And so that is the ICOPE implementation pilot program, Ready, Set, Go. Next slide, thanks. And we are right in the midst right now of having the WHO Ethics Committee assess this ready phase. At the Clinical Consortium Healthy Aging meeting in November 18, our various members will be reporting on their initial experiences in implementing ICOPE in various different countries. And then we will progress to actually sending out these ICOPE scorecards and the micro surveys to our participating members, so that we can start to understand in a more fine detail what is working and what needs improvement. and then we'll be reporting this to the WHO and the CCHA. And then, of course, begin to plan this set phase 2 part of the study, which is the prospective trial in 2 member states. So I hope that's kind of conveyed what is ICOPE and our pilot implementation program, Ready, Set, Go. And of course, I am merely representing a group of individuals that have been working on this for so long. And I want to finish by honouring the member of our late and dear colleague who was the instigator of the ICOPE, Dr. Islaini Araujo de Carvalho. Thank you very much.
Thank you, Professor Michael Valenzuela. Dr. Anjan Trikha has to leave for a national seminar. So at this point of time, there are no questions for him. So I think he can go. If there any question comes, I will try to respond and we'll contact him. Professor Trikha, thank you for being with us, and happy to have had you and to learn from your experience. If there are question comes, I will be calling you and taking your response.
Thank you for calling me on the phone. Thank you very much. And it was be here.
Thanks. There's a question for Dr. Kitty. What is the cost of that mini this thing you just hold on for a minute. How much that a mini robot cost? Do a lot of Thai families buy this elderly care at home? Dr. Kitty?
Okay.
How much it costs, and do a lot of people in your country buy this for old age care?
The mini robot, install mini robot.
Yeah.
I think that the cost is, I cannot inform exact number because I have no only approximately. It depends on the number of the robot that we buy too. As I know, to my knowledge, it may be above 50,000 Thai baht. 50,000 Thai baht. So
not very costly. Not very costly. 50,000 Thai baht for
yes.
so much of utility. But do a lot of people buy them? People are kind of going for it.
Not many people buy them. This program has been launched lately,
Okay.
but there are not very much. We have tried in some area for the pilot project. Maybe in one community we will have about 3 to 5 robots in
Okay.
the village, but not all village, because this is in the beginning process. So
yeah, it has come now, and when the prices go down and it gets popular, people will buy them. There's a question for Professor Michael Valenzuela. Can you have ICOPE implemented by training the caregivers at home? Is it possible that the family caregivers can also be trained in ICOPE screening and detailed assessment, and can replace the primary health care for a while?
Yeah, I mean, that would be wonderful if that were possible, but I think more realistically, let me step back. In terms of some of the preliminary insights that we've been hearing about informally from those member states that have been trialing into implementation of ICOPE, there's been, let's say, 3 kind of key insights. So one is that member states have been quite focused on step 1 of the whole process, which is screening. And that's great, but the reality is that screening is merely step one of a 5-step process. And so what is really critical is building up both the competency around ICOPE at the micro level, but also ensuring that that shakes hands with the rest of the system, so that you're not only identifying issues, but you're responding to issues, and then that is being followed up in the community. Now, in terms of screening, all of those member states have been relying on volunteers of one form or another. So, for example, the village healthy volunteers Dr. Titi was talking about in Thailand would be a great example of the type of workforce that could help in step one of an ICOPE approach. And the other response to that question is that the whole ICOPE pathway fundamentally relies on assessing the social environment and ensuring that there is carer and a community there to help action and motivate whatever pathway changes are required. So to kind of a long answer to what should have been a simple question, but it's a complicated issue. There is very much an important role for carers, but it's part of a community and a network. ICOPE is really not about one individual magic bullet. It's about a micro, meso, and a macro change to business as usual.
I'll ask a question to Yuka. How frequently you are giving guidance from WHO side on COVID issue? I mean, it's a weekly, monthly, or what sort of plan like? No, we have the clinical guidance, then we have the LTC guidance. Do you have anything else in your mind as to more critically looking at vaccination guidance or something? Are you trying to plan? Are you planning to have something maybe every 2 weeks or 4 weeks?
Thank you for your question. Of course, it's, even headquarter or regional office provides the guidance. It's up to the countries to take, if they can use the guidance in the field or in the healthcare setting or any other settings. So we all involved all the country offices and regional offices to understand what are the needs and what is the effective way to deliver to them, to the specific audience. Some guidance are targeting clinicians and some are policymakers. So based on the target audience, we have a different platform. For example, regional conference every week and other conference, and sometimes we have also webinar involving all the UN partners. We try our best to deliver effectively the guidance to be used. And in terms of the COVID vaccine guidance, we have an expert group and we have a huge group for the vaccination in WHO. And I have to admit that, traditionally vaccination work is targeting children, baby and children. So it's influenza vaccination or pneumococcus vaccination is more adults. And the COVID vaccination, actually high risk group is adults or people with underlying conditions. So we need to find a way how effectively we can deliver these guidance and the vaccine itself to these target groups. So now it's ongoing process, and we are involving all the stakeholders, NGOs, so that we can understand the needs and what kind of platform in the community they have. So as soon as we develop the guidance, we will disseminate and to update the guidance, because all the guidance are living document and we don't know how the vaccine looks like. There are so many vaccines in development. Thank you for your question, Dr. De.
There was a question for Dr. Anjan, which I will answer now. The question is that 65 plus people are having with pre-existing health issues are prone to COVID plus. Are they dying because of age or because of the disease? Actually, they are dying more because of the comorbidity than the age per se, not that every 65 plus who gets a moderately severe COVID-19 infection will die. It depends on what is the pre-existing health issues and how bad are the comorbidities, and that will probably determine the risk of dying. Also, more importantly, the severity or the dose of infection that one has received. So these are issues. The epidemiology of COVID-19 is yet to be fully described, but this much we know that older people are at high risk, and that's why in many countries, like say in India, all 65 plus have been asked to stay at home and not to go for work. There is one response which has come, I think Dr. Kitty has given it, but this is about Thailand, that in Thailand they have already started piloting ICOP screening. Dr. Michael, this is for your response. In Thailand, we have started piloting the ICOP screening for older people in villages through healthy volunteers, and about 30,000 people have already been are planned to be covered, and 5,000 cases have already been done. So 5,000 per province, 6 provinces. So they are planning to do 30,000 cases by healthy volunteers. Your comments, Professor Michael. Agree, thumbs up.
Yeah, that's
it's
magnificent.
Thank you very much.
Congratulations. And Yuka and I will be in touch with you to understand that more.
Okay.
Yeah.
My pleasure. Thank you very much.
We haven't have any more question. As no more question has come, I hand over the mic to Dr. Nina Raina to summarize and give her expertise and opinion and management issues and issues like that, and then we'll close. Dr. Raina, please, for the closing comments.
Okay. First of all, thank you very much. I'd like to thank the panelists, Dr. Yuka, Dr. Anjan, Dr. Kitty, and Professor Michael. I think this is a wonderful opportunity for us to really bring all of you on board and have a very diverse, what should I say, diverse take on the essential services for older people. And, I would say never, it's always said, never waste a good crisis. The COVID-19 challenge has come with a huge opportunity for us to advocate for older people. The investments either from donors or from countries has been very limited in older populations and elderly. And I see, especially in our part of the world, there are very few ministries of health who are really focusing on a national program on healthy aging or for older people. And this is the time where we need to bring all the sectors together, not only health, but other sectors where, because many of the older people, so-called, I think I agree with you when you say, Dr. Anjan said, 60 plus should not be older, but I think we are saying age is just a number. But then most important part is that what are their intrinsic capacities and what are the functional abilities to be able to cope. And for that, we need healthy cities, we need healthy clinics, we need, age-friendly cities, age-friendly hospitals, we need age-friendly facilities. We need to also look into the economic side of it. But health side, I would say we are the ones, ministries of health are the ones who are good advocates for increased investments in this age group. And Dr. Kitty, I think Thailand is taking the lead in this area, especially by focusing on older people. And especially Thailand and Sri Lanka are the two countries in our region which are really trying to now focus, because the percentage of population which is in that bracket is increasing. So this is a COVID-19 as a challenge, I would say, is a good crisis for all of us to be able to convert it into opportunity for increased investments in older populations and healthy aging program. 1st of October, we launched Healthy Decade of Healthy Aging. Now it's not only WHO, it's the whole UN program. So decade from 2020 to 2030. So with these words, I would say that I would like to also, thank all the participants who have remained connected with us. We had about 250 at one point who were connected and were listening. I would like to thank the panelists once again, and most importantly, Dr. Day, who has been a pioneer in our region to be able to bring geriatrics, in the forefront for moderating this session. I would also like to thank Dr. Shyam Pingle, who is representing Professor Dilip Mavlankar, Director of Indian Institute of Public Health, for this collaboration. And my special thanks to the team in IAPH, Kalpana. Dr. Kitty, I know you were brought in at the last minute because you were not you were not able to connect you because of certain emergency, which happened at your end. And I'm so glad that you could come and really share the experience. So I think this is where artificial intelligence is coming in a big way to support. And this is a good way to bridge the generation gap, where you're using artificial intelligence to support older people, at home. So, with these words, I'd like to convey a big thank you to all of you and IAPH team, especially Kalpana and Neeraj Solanki. And from my team, Mr. Amit Sood and Dr. Meera Upadhyay, who has been coordinating and making sure that these webinars are a big success. Stay connected. This is next Wednesday is our last webinar of this particular series. But as I said, there are 4 webinars which we are organizing, and tomorrow is another one. First was on 12th of October on school reopening. So because we cover the whole life course, so from pediatrics to geriatrics. So I think this is a good opportunity for us to really stay connected and learn from each other during these difficult times. Thank you all the panelists, and thank you Professor Day, and also Dr. Shyam Pingle for staying with us, and all the participants. Thank you very much. Have a nice day. Bye-bye.
Okay, thank you.
Bye-bye. Thank you very much. Thank you very much.
สวัสดีค่ะ
สวัสดีครับ
สวัสดีค่ะขอบคุณค่ะ
ครับขอบคุณครับขอบคุณมากครับ
Okay, bye-bye.
Okay, bye-bye.